All right, this is case one. Here we've got a punch biopsy that's been bisected, and the left side here looks different than the right, okay? So let's go down and look at the left side, which is where the classic findings are. We've got a blister. It's an intraepidermal blister. There's some basal layer keratinocytes retained down here on the floor of the blister, and the roof has separated. And in the blister cavity, you can see, once it comes into focus, that there are free-floating keratinocytes here that have detached from one another. So that's acantholysis. So there's some immunobullous diseases like pemphigus, for example, that can have acantholysis and blistering. But this is not immunobullous. This is actually a viral disease. And I forgot to mention at the start, we're going to be talking about viral diseases today and a few mimics. So here we have detached acantholytic keratinocytes that are rounded up, some necrotic material in here, and it's hard to see in these cells, but let's go down here into this opening of a hair follicle. And if we look closer, we can see the classic cytologic features here. These are keratinocytes that have multinucleation, molding of their nuclei together, and margination of their chromatin, the 3 M's of herpes. And that can be seen in both in herpes simplex virus and also varicella zoster, VZV, which is what this is right here. This is VZV. And the only way to definitively know that is by doing an immunostain or PCR. To tell apart simplex and zoster. The cytopathic change looks the same for both of them, at least to my eye. The one other, obviously also the clinical presentation usually can help you quite a bit. If it's spreading along a dermatome, then it's zoster, right? Almost certainly. Or if it's, a lesion on the lips or on the genitals, it's more likely simplex. One other microscopic clue is if you have a lot of hair follicle involvement, that tends to be more common in varicella zoster. And one thought for that is that in zoster, the virus goes and resides in the sensory nerve ganglia, and then when the virus reactivates, it spreads back through sensory nerves along the dermatome, and then some of those nerves, it seems, connect to the root of the hair follicle and allow the virus to first infect the cells there, the keratinocytes in the hair follicle root, and then from there spread up into the epidermis. So that's why we tend to see herpes folliculitis or follicular involvement by herpes more often in zoster than in simplex. But this is a perfect example of the 3 M's of herpes, and some people will make a 4th M and say mega cells, meaning the cells are really big and large because they are enlarged. The central part of the nucleus has this kind of hazy ground glass, I'm using air quotes here, or frosted glass appearance, that's smudgy kind of gray look, and that's because I think they're filled with viral particles, and then the DNA gets pushed out to the side and compressed along the margin of the nucleus, along the nuclear membrane. It looks like someone took a dark, purple marker and drew around the outside of the nucleus. So those are the classic cytopathic changes of herpes. Sometimes they're really perfect, like here. Other times you kind of hallucinate them a little bit in the dead and dying keratinocytes in the center of the blister cavity. And that's especially true when there's a lot of necrosis, a lot of inflammation and neutrophils, which is actually, I would say, more often than not what I see in herpes is I see this really inflamed necrotic ulcer. Maybe the blister is not even visible anymore because of how much necrosis and inflammation there is. So look at the adnexal structures to try to find the best viral cytopathic effect. Also, I find looking at the free-floating cells in the lumen, like we saw earlier, or excuse me, in the blister cavity, and also looking over here at the peripheral edge where the blister or the ulcer meets with the intact viable epidermis. You can see some viral cytopathic effect right there. So I find those are the best places to look for viral effect. And then oftentimes I will do the immunostains for HSV 1 and 2 versus VZV because I have them readily available in my lab. And I find that my treating physician colleagues, my dermatologist colleagues, usually like to know if there's any doubt clinically which one it would be. They like to know because they do change the medication regimen to some extent based on that. So you can talk to your clinical treating physician colleagues to see if they need to know the difference or not. Otherwise, I just call it herpetic dermatitis and add a comment that I can do the stains to sort out HSV versus VZV if clinically indicated upon request. So this is herpes. Oh, and then the other side here, I think it's worth taking a look here. This is a kind of what happens when the roof of the blister has totally sloughed off and been detached. And this is true of any sort of acantholytic blister, that you can lose the surface because it's lost its connection with the base of the epidermis, and so it can detach and either be lost during processing or sometimes be found floating elsewhere on the slide. You can see, just like you would see in pemphigus, you've got kind of a tombstone row of basal keratinocytes that are mostly intact. But here it's subtle, but there are some hints of viral cytopathic effect there, which is a clue that we may be dealing with herpes. And when we go over here and look down this adnexal epithelium, I'm not sure if it's a hair follicle or a sweat duct here, but you can see better multinucleation, margination, and molding, and that smudgy, hazy ground glass nuclear chromatin pattern that's typical of herpes. All right. And a lot of inflammation in the background dermis, another typical finding in herpes.